Hi everyone, my name's Professor Peter Nash from Griffith University, beautiful downtown Brisbane, and I'm reporting for Room Now, EULAR 2023 in Milan. Jack has asked me to focus on the JAKs and the TYK2s in this meeting, and I'm presenting to you a abstract called Late Breaker 001. The room was packed when this was presented. This is a Chinese study done in Chinese patients. And it's looking at a selective dual JAK1 TYK2 inhibitor called TLL-018, and they compared it head-to-head with Tofacitinib in patients with rheumatoid arthritis. So we know what to expect with Tofacitinib. We have a feel for how that would work at the ACR 20, 50, 70 kind of level, and so we can compare that with this new drug. Now, they looked at 101 patients with active rheumatoid. As I said, this is in China only. They looked at those who were MTX inadequate responders or MTX intolerant, and they randomized to this oral dual JAK, JAK1 TYK2, in 3 doses, 10, 20, and 30 milligrams, and compared that with the 5 milligram Tofa, both of them, the TLL and Tofa, twice a day. And they looked at them for 12 weeks, quite a short study, quite small numbers in each group. Now, these were a difficult patient population. Half of them had already failed a biologic, and 30% had had a trial of a prior JAK, including some of them had already tried Tofa before. The exact numbers weren't declared, but the paper will illuminate that. And certainly some of those patients would have failed a BD-MAD and a JAK. So they would be a tough group to treat. Now, the primary endpoint was ACR 50 at week 12. The secondary endpoints was DAS28-CRP. They did not do a CDAI, which is usually helpful, as many people say that the JAKs mechanism of action bring the CRP down, so you should look at CDAI, which has no CRP in it. They looked at DAS28-CRP remission rates. They looked at ACR 20, 50, 70 at all scheduled time points. They mentioned the CDAI as a secondary endpoint, but didn't see it presented, and other parameters at week 12 for safety. Now, they showed Tofa responses, ACR 50 and DAS28-CRP remission, 42% for Tofa, which is about what you see, 60, 40, 20 with Tofa in rheumatoid studies, ACR 50 at week 12. A little bit better than, say, oral strategy, where that ACR 50 for Tofa was really in the 30s rather than the 42s, but there you go. And DAS28 CRP remission rates for Tofa are about 17%, which is about right. But the 3 doses of the TLL-018, 10, 20, and 30 milligrams BD, had responses, particularly at the 20 and 30 milligram BD doses, that were in the order of ACR 50, 65, and for the higher dose, 72% of patients in a BD-MAD IR population getting an ACR 50 of 72% and getting a DAS28 CRP remission of 55%. So unbelievable results. They were significantly better than Tofa at ACR 50, both the 20 BD and the 30 BD doses, and the kinds of adverse effects that they found with the usual hyperlipidemia, some respiratory infections. They had 1 malignancy in the Tofa group, but no death, VTE, or MACE. So these results really are outstanding if real, because all they've done is add some JAK2 inhibition to JAK1, and we know how the JAK1s work. So why should simply adding that make such a huge difference? There's another JAK1 TYK2 inhibitor, Tofacitinib, but that was studied in PSA where it's effective, not in RA as far as I'm aware. And they're now going to roll this out internationally in multi-centers to see if they can reproduce these results. Look forward to that coming to somewhere near you shortly. Very impressive results head-to-head against TOFA. No new safety signals, they claim. Efficacy, as we said there. They're going to do this multinational study not in MTX-IR patients, but your patients that are the most difficult group, the BDMARD inadequate responders or BDMARD intolerant patients. So they're niching themselves from the start with this particular study, and we look forward to the findings. Thanks for your attention. Back to you, Jack.